I think what we'll start is maybe just a quick buzz through the pre and post slides from the the sexual health and HIV and sexual health workshop in March, and just to get us all in the right mindset, and so that you can kind of remember what the issues and the topics were. Then we thought that Suzanne and I would do a little bit of role playing, since there were a number of people who had never done pre and post test counseling before or seen it. So we thought that maybe what we'd do is run through a few scenarios just so that you have the bigger picture of what the variations might look like. We thought we would do a really simple minimal counseling, that we would do maybe a little bit more realistic minimal counseling that you could then role play for physicians or primary care providers or whoever testers in your region, so that at least you would have seen that, and those will be short and sweet because it won't take long. Then we're going to do one that will be probably more representative of what maybe Clarence does a lot of, people who are sort of middle of the road. You'll see that we don't go through every point on from all of the slides. That would take 45 minutes or an hour, and very few pre-test education sessions take that long. So we'll try to do something that looks a little bit more typical. So this again is just exactly what you have on the DVD of that preliminary set of slides from March, but we thought we'd just quickly go through it. We won't go through those objectives again. You remember about the routine testing was being the impetus, and if you had to put more effort into the routine testing, the categories that you would spend a bit more time on, the idea of emphasizing the 3 C's, remembering that HIV is reportable, some concepts again about the idea of it being unethical, certainly in poor practice, and it is actually contrary to legal doctrine to do testing without getting informed consent. So the confidentiality part, the fact that HIV is reportable, that there's disclosure implications, and what will happen with results either positive or negative. The idea that counseling is client-led, and that's why every single one is going to look different. There will be some that are the absolute minimum, and there will be the odd one that's an hour, but most are going to be some variation in between there, and we'll try to show you a few of those. So then the points to remember for minimum counseling is some indication about the benefits of early testing, making sure that people understand that they have the right to opt out, the idea that HIV is reportable, the idea that there is follow-up and support available, the idea that there would need to be some follow-up with partners or contacts, that if people test positive that there is disclosure issues, and again, remembering that that's sort of all that's required in most settings. Then the in-depth stuff. What if we do a couple of minimum requirement counseling first, and then we'll come back to this slide. All right, so hopefully you've got us on the big screen now. And I'm going to actually refer, I know you can't really see these very well, but I am going to actually make use of these documents, try to get my face right here, the documents that came with the toolkit. So this is the client information sheet, the one that's got the bright green down one side and the white banner down the other. And later on when we do the in-depth counseling, this is the in-depth counseling sheet that's part of that resource kit as well. So just so that you know what I'm referring to. But okay, so in the first scenario, I'm going to be a primary care provider who is coming into the room to meet Suzanne. I don't know her very well. I think I've seen her once to, I don't know, pull out a sliver or something like that. And she's, you know, come into the practice, was sitting in the waiting room for a while, has been sitting in the exam room for a while, and I've just come in. Oh no, and actually, why don't we say I've done my physical exam and done my history, so I have a sense about what her situation is and how she fits into the routine testing, and I've decided that she really is just a routine testing client. So, okay, Suzanne, I think we're all done here. If we've taken care of the things that you wanted to talk about, you have me check out for you. So I think we're ready to now just have me order the testing for you. I'm going to get you to go over to the lab, and we talked about having that routine chest x-ray and getting some blood work done. So, so I'm going to get that checked off. And so before I do that, I just wanted to make sure I know that when you were in the waiting room, I know that our staff handed you this routine testing information sheet because the province has now started doing, recommended that HIV testing is routine. So did you have a chance to take a look at it? Is there anything that we should be discussing in any more detail at all?
No, I did read it, but what does this mean, this routine testing? What are you, why are you offering this to me today?
In the past, what was happening is that depending on what information practitioners got from their clients, they would have to make a judgment, hopefully with the client, to decide whether there was enough risk to warrant doing HIV testing. But because HIV is becoming more prevalent in the province, and because it was decided that people were being missed when we were having to figure out amongst ourselves whether a client, whether you would qualify or need to have risk-based testing. Last winter, just before Christmas, I think they came up with the recommendation that it makes far more sense. It's a nice, easy, simple test, and that we should just be offering it to people routinely. So from our conversations, unless there was something more that maybe you wanted to talk about, but it seems to me that you fit into the routine category. You tell me that you haven't been tested for quite a few years now. You know, that it makes sense for us, I think, to include this in your routine stuff and go from there. Certainly.
So you do this for everybody then?
Everybody that I'm seeing that fits into that routine testing, that I'm not aware of any risk factors where I might do things a little bit differently. But you know, for general population, yes, I am asking everybody now, and we're going from there. So, of course, it's your choice. You ultimately are the boss and have the right to say no if you don't want to. It does. Everyone expects to be negative, but if there were health issues, if there were symptoms, if there were things that I needed that information for, it would be a critical piece of information so that I could provide you with better care. The sooner we become aware of somebody who is HIV positive, the sooner we're able to work with them to make sure that we keep them healthy, get resources for them, that kind of stuff. And also, of course, because it's a reportable disease, just like chickenpox would be, any of those things, we would talk about contacts and who else might need to be tested to make sure that they're okay. And of course, people that you care about and love, we would want to make sure that we're looking after them as well, right? You know, so of course, that's worst case scenario if the result comes back positive. But again, the routine testing is just something that I'm trying to incorporate into my practice, and so this is kind of new for me too, but it makes good sense, and so I'm happy to offer it to you, and I'd like to go ahead if that's okay.
Yeah, that's fine. Yeah.
Okay, so I am documenting that Suzanne consented to the routine testing here, and checking it off and sending her on her way. So things that you might want to cover with somebody, depending on what read you're getting from them and what information they give you, are how much you need to go into the biology and the basics and the testing process and that kind of thing. How much you need to sell it in terms of pointing out the benefits, and how much you need to assess the risk to make sure that you feel comfortable, and of course that the client feels comfortable to consent, in terms of is this really safe and is this the appropriate decision to go ahead and do the testing for them. Again, a little bit more of the intricacies of the testing, depending on the client and the circumstances. They may want to know an awful lot about this. So some of the clients come in with a lot of questions about this, and some don't at all and really don't want to know too much about this. So the window period one, I think, is fairly critical, just in terms of people understanding where they fit in the window period, as Janice said, when they need to come back, and how to interpret the results. So usually that's something that we go over. Risk factors and minimizing risk and harm reduction down at the bottom of the slide there, looking at other variables that might impact the client's ability to keep themselves safe and make safe decisions and look after themselves, and readiness for change in terms of whether they want to pursue some briefer screening, maybe some minimal intervention, and maybe some even referral to resources depending on what they reveal.
And I would just jump in to say, for people who have done the pre-test counseling piece or have had to give a result, particularly a positive result, that is the most important piece, is that pre-test piece. If you've ever been in a situation where you do have to disclose a positive result to someone who's not had that counseling up front, they really, well, and we've talked about that, they really just don't hear anything that you have to say. but the pre-test counseling piece, particularly for at-risk populations or clients, is really borne out sort of through the process if you do have to give a positive result. It's very beneficial.
Other things that may emphasize more or less are that support and coping thing. The how to obtain results, particularly if you're dealing with hard to reach clients, the idea that they need to come back for the results unless where you're doing your presentations or where the testing takes place has a different policy, but this is what we consider best practice, I guess. And how to find the clients is really important. And then again, as I say, referrals. Consent part, again, as we've said, it needs to be informed, voluntary. They need to know that they can decline, that it doesn't impact their care, that it's safe for them to agree to be tested, the disclosure stuff, and the idea that you have to document whether the client consented or not, but that you offered testing.
I would just say for everybody who's on the line, just to maybe check with your regional policies. I know that Saskatoon Health Region did have this listed as something that was requiring written consent, and I know maybe Denise or Janice, you guys can speak to that. I know that that was in the process of being altered. For us in our QHR, it actually is not specifically listed in our consent policy at all, and so I've discussed that with risk management. They have no desire to open the policy up, but we've at least had the dialogue, and it's fair for us to say that written consent is not required and to support that with risk management's blessing, essentially. So it just would be good for you guys to know exactly what is existing in your region and have that dialogue.
And for all that, we've been talking about consent and documenting and all that kind of thing, the new documents will have places for check marks to indicate that consent has been obtained or not. But this is the sheet that I have been using for my pre and post test counseling, and I'm looking at it saying, there is nowhere on this document for me to indicate that I offered testing and that it was accepted or declined. So I'm going to have to just change my own personal practices. Yes, but it doesn't say HIV, and when I check off HIV, I'm not indicated. It's implied. They stuck out their arm and they let me do the test, but no, I'm going to have to make sure that my documentation is appropriate and maybe edit this form as well. And so again, the more of the communication skills and the recommendations in terms of acknowledging the personal nature of the conversation, watching your language. And again, I have to say it's really interesting when we were showing the video clips last week to a different audience that some people took exception to things. There are things that can be done much better in those videos, but some people took exceptions to things that I thought were perfectly acceptable. So it's one thing to sit and to critique a video when you're actually looking for things to be critical of. It's also different when there isn't that pre-established relationship, when you just jump into this personal stuff without knowing the interaction between the people. Sometimes something that sounds like it maybe wouldn't go over very well, or I wouldn't say it that way, is actually perfectly appropriate given their relationship. So, it's going to take practice. You're going to need to figure out what works for you, what fits your personality, fits the environment and the circumstances that you're doing your testing in, and your relationship with your client. But you're always learning, and you're always getting better, and you're always figuring out better ways of doing or saying things. So I think we'll cut the slides here. Okay. And anybody have any other comments or issues before I throw myself under the bus and do a bigger pre-test education session at all? Okay then. So our scenario, I don't know what Suzanne is going to say particularly. I thought that would help keep me in the moment and worry less about what I'm saying. So we agreed that our scenario would be that she's come into my clinic, and I don't know if it's the sexual health clinic or one of the outreach clinics or whatever, but she has just presented spontaneously, and I'll figure out what she's here for. So. Hi, Suzanne.
Hi,
I
Michelle.
Understand you were looking for me. What can I do for you today?
I think I need to get some testing done today.
Okay. What kind of testing were you looking
well, for sure I need HIV testing, I think.
Okay. So the way you say that makes me think that maybe there's something that's happened or a reason that suddenly this is important.
I met somebody and I had some drinks and we had sex and we didn't use a condom, and so I don't know this person very well, and so now I'm kind of worried because I don't usually do that, but you know, it just kind of happened, and yeah, so now I'm kind of anxious.
Okay, yeah, I can understand that. Sorry, when did you say this happened?
About 3 weeks ago.
Okay, all right. So that's great. I mean, I'm glad that you're here. It always takes up a bit of courage to come in. I know it's not an easy thing to do, so good for you. And again, let me reassure you that you can't shock me, right? I've been doing this job for a long time, so you know, whatever you need to tell me, just tell me. It'll make it a lot easier for us to be on the same page, for me to help you understand where things are at and what the results mean, and all that kind of good stuff. So, you know, you won't make me blush, I promise. And again, whatever we talk about here is going to be kept confidential. You know that. I'm sure that you've been told that before. But you know, I keep this is between you and I, as long as the results are negative. If anything should come back as being positive, that's reportable, that public health has to be automatically notified about. The lab does that automatically. There's a list of things, and it's from, you know, chickenpox to TB to HIV.
So,
or whatever,
so I think this person works at the lab, and I'm
your partner, you mean?
Well, the person that I had sex with. So
Okay.
I'm kind of worried about that they might find out that I got tested. And
Okay.
I don't really. I'm
Yeah.
worried about that.
Yeah, fair enough. So there, let me tell you the options, and you can tell me what you feel comfortable with. First of all, to reassure you that there are millions of tubes of blood and millions of pieces of paper going by, and people are not reading all of those labels. So that's the first thing. The second thing is that if you really are not comfortable to have your name on it, I do have the option of putting a code on instead. I still have to have your health number and your birth date, which I'm sure that person would not have memorized. But I don't actually have to write your full name on there. So that would be our second choice if you wanted to, if you were comfortable with that. It's always better to have it done by name for our purposes for the chart, but I'm quite comfortable to do the second if that makes you feel better.
Do a lot of people get tested like that?
A fair number, yeah. Different places do have different practices, but here in the area that I work in, yeah, a fair number do.
So my name's not on there at all?
Your name, it would be the first two initials of your first name, first two initials of your last name, and the last two numbers of the year you were born. So that I know who you are when the results come back. I can, you know, find your chart and get it to the right place, but nobody looking at that would know what it means. So does that work?
That sounds good. Yeah.
Okay, all right. So maybe to start off with some easy stuff and work our way into the more sensitive things that you maybe want to talk about. I'm just going to get the chart started here, okay? So I know how to spell your first name, but can you spell your last name for me again, just so I have it right?
Nasewich.
Okay. And your date of birth? Oh, she gives me the evil eye.
Sidebar. I'm not. Yeah, I'm not. I'm gonna say. How about March 10th, 1987?
Perfect. All right. Do you know your health number?
No, I don't. I'll have to give you my card.
Okay. Perfect. All right. And for the lab forms, I need to indicate male or female. Which would you like me to indicate?
Female.
Okay. All right. And your address. We have an address on your chart. Is that still current? Is that where I would find you? And if I were looking for you in a week or two, the phone number and address on there are okay for me to
I'll actually give you my cell phone.
Okay.
And if you need to get a hold of me, that's the best way, because I live with somebody. And
okay.
Yeah.
So so not to call that number at all?
Don't call my home number.
Okay, I'll make a note of that.
No.
And so when I call your cell phone, you know that you need to come back in for the HIV result, right?
Okay.
So I can't tell you the results over the phone, whether it's good news or bad.
So you'll call no matter.
So I'll call you when the results come back.
Okay.
But all I'm going to say is, "Hi Suzanne, it's Michelle. Give me a call." Okay. So don't read anything into that. That's what I say to everybody.
Okay. Yeah.
All right. And there's nobody that listens to your voicemail on your cell phone.
No, it's my personal
But
cell.
okay. Yeah. But I won't say anything more than that. So okay. So I'll put down that we're going to do a check here. Symptoms, and now of course for HIV, the symptoms usually are more long-term symptoms that come long after an infection. But sometimes people will also have some symptoms when they're first infected. So how have you been feeling, and have you had anything that
I've had a cold and the sniffles. So would that
mostly
be something?
Mostly in your head and the sniffles, fever at all? And
no, runny nose and sneezing and coughing a bit. Okay. So is that something to worry about?
That isn't particularly. All of the symptoms are actually symptoms of many viral infections, amongst other things, right? So for the most part, we don't go by symptoms, but if we have a result and we have symptoms to go with them, that gives us a fuller picture. But we never just go by symptoms, we always go by the lab test
So
first.
having the sniffles, you don't?
No, that's not
sure?
something. Yeah, that's not something that I'd be looking for. If you have other symptoms, you can make sure as we're talking, something else comes up, by all means let me know, but sniffles are not one of them.
Okay.
I'm going to come out of character here. I tend oftentimes not to list the symptoms, because as you list them, they suddenly remember that they have all of those. So I tend not to ask the leading questions here if you're wondering why. And other people may have a different approach. That's just me.
Well, and I think just to add, if you were an introspective person, I could easily go down that road, right?
Yeah. All right. So you said that this particular event that you were concerned about, this potential sexual exposure, happened 3 weeks ago?
Yes.
Okay.
Yeah.
And were condoms used? Did you say it was unprotected?
No,
right?
unprotected.
Yeah.
No,
okay.
No.
All right. And the person that you had sex with, I think you referred to the person as a he. Was it male?
It was a male.
Okay. All right. And when we are thinking about how HIV is transmitted, it's important to know what body parts have touched what body parts and what's fluids. So usually I say,
you're going to make me tell you what we did?
I'm not going to make you do anything, Suzanne, but it does help me to know in terms of risk. So with a male, then it would be, was their penis in contact with vagina? Did the penis go inside your vagina?
Yes.
Okay. Any other kind of contact with this penis with your mouth or your bum
yes.
or anything else?
With my mouth.
Okay. And did you have contact with anything besides his penis? Did you have contact with his bum or any open wounds or anything like that?
No.
Okay.
No.
And kissing mouth contact?
Yes.
And you're not aware of any blood in his mouth or anything like
no.
that? That would be a concern.
No.
Okay. All right. So write that down. Any other interaction between the two of you? Did you share any kind of drugs at all? Was there any equipment that might have been used?
Who sees this?
Well, as I say, this stuff here is you and me.
Nobody else sees this.
If it became positive, the province and the federal government wants statistics. So they don't want to know Suzanne Naswich did this. They want to keep track of how many people were exposed sexually, how many people were exposed by injection drug use equipment, those types of things.
No,
so they're not going to want to know your personal details. I'm the only one who has that.
No, we smoked some pot. That's it.
Okay, and that's not, again, unless he had blood in his mouth and there was blood exchange and you had open sores in your mouth, we're not worried about that. So that's fine. Sex toys at all? Any kind of equipment that was used? Any sexual practices, S&M kind of stuff where there might have been more blood? Any breaks in the skin? Anything like that?
No.
All right. I'm trying to think of what else here. So the smoking was just a joint type of thing. There were no hot pipes involved or anything where your mouth could have been burnt or whatever.
No.
All right. So a little bit more general kind of questions then, unless there's anything else about that particular possible exposure that you think I should know?
No, it's just, I guess I'm worried just because I don't know anything about him, so.
Right. And so I guess to try to help you sleep at night a little bit, to know that the incidence of HIV in the general population, I think people overestimate, and certainly because we're talking about, even things like in routine testing going, that we're trying to increase the profile of it, but conversely, we don't want you to be thinking that every exposure is going to result in an HIV infection. Even if this person had HIV, the odds of you getting infected are, far, far less than 50-50. Even people sometimes think it's, 100% if they have sexual exposure to somebody with HIV that they're going to be infected. So it's much, much less than that.
Even without protection.
Even without condoms. Yeah. Okay. Mm-hmm. So if that makes you feel a little bit better. Okay. But so moving away from that one particular situation that you're worried about and going to a bigger picture then, your last time you had sexual contact with anybody, anyway, anyhow, anywhere,
besides
was how
this?
long ago? Yeah.
Well,
or including this one. So was this the most recent?
Yes.
2 weeks ago?
Yeah.
Okay. All right. And so the number of people that you have had some kind of sexual contact with in your whole life, and you don't need to give me an exact number, but a ballpark, 1, 5, 10, 50, 500, 5,000.
5,000?
Some people.
15.
Okay. All right. And number of partners in the last 6 months?
3.
Okay. Any of those partners, did you have a reason to believe that they might have been involved in sex trade, where they're taking money or drugs or something else for
No.
sex?
No.
Or any other high-risk activities? Any partners that you believe had injected drugs?
I don't think so.
Or disclosed to you that they had
No.
some kind of
They didn't.
infection, HIV or otherwise?
No, they didn't say.
Okay, good enough. And you don't actually live with somebody who has any of these infections?
Not that I know of, no.
Okay. And sharing razors, toothbrushes,
No.
acupuncture,
No.
needle,
No.
any kind of
That's
medical kind of stuff. That it's sometimes even medical procedures in other countries. Last time that you've been out of Canada or the States?
Probably 4 months ago.
Where did you go?
Mexico.
Okay. And how long were you there?
A week.
And did you have like any kind of treatments that might have broken your skin, involved needles or,
No.
or medical equipment or anything like that? All right. Last time you had, or have you ever had a blood transfusion?
No, never.
Okay. And piercing, tattoos, anything like that?
Not currently, no. Just my ears.
Okay. And how long ago was that?
Oh, when I was like grade 1 or grade 2.
Okay, so a long time ago.
Mhm.
And so I guess that leads to then, do you remember the last time you had an HIV test done?
No, I don't. I donated blood maybe about 10 years ago.
Okay.
Would they have tested me then?
They would have, but it would have been a different test from what we're doing
Okay.
now. But since then, to your knowledge, no healthcare provider that you've been to.
Would they,
has
well, I
tested
go for my checkups,
Right.
for my pap test. Do they test me then?
Not unless they specifically speak with you. They should actually have made it very clear to you that you were getting tested, and they should have known if they did.
So if I said just test me for everything, that wouldn't do it?
I can't speak for certain, and if it becomes an issue, I can look into this more. But don't assume when they say, when I say,
Okay.
test me for everything. Oftentimes, most of the time, not.
Okay.
Okay. So
Mhm.
yeah, so we'll look into that. But you think that you donated about 10 years
I think
ago.
so.
Okay,
Yeah.
good enough. And sorry. So you said the piercing for your ears when you were small, and no other tattoos or anything
no,
like that.
no.
Okay. And again, medical history. Anything that I need to be aware of? Medical conditions or anything? Medications that you're on? Anything that you're allergic to?
Nope.
Okay. All right. As part of the bigger sexual health assessment, there are spots here for contraception and pregnancy and pap tests and all that kind of stuff, but for the purposes of this role play, I'm going to pass on all of that. So since you haven't had an HIV test before, do you have a general understanding of what it involves, or are you interested in my kind of explaining
Well,
a
I
little
want to
bit more
know.
to
I want
you,
to know
or?
when I can get a result. Like how long do I
Okay.
have to wait? I want to know about the results.
So in my clinic, we have a couple of options. We're, Tuesday today. So we can talk about whether you think that you're in a position that you want to have some testing done where I do it with you right here now today. And you could walk out of here with some results. It's called point of care, and the results are, if the result is good and it says that you are non-reactive, that you don't have HIV right now, then that's good enough for us for now, and we leave it at that. If there was anything that looked questionable or looked like you might have HIV, then we would need to follow it up. It would be considered preliminary, and we would always do a double check. So then we would have take blood out of your arm and send it for the tube off to the big lab.
But I get to know today.
You would know the first part today, but the second part could take 1 to 2 weeks to come back from the lab.
Yeah, I want to know today.
Okay, so just so I can tell you, the other option is that I would only take the tube of blood. They would do the equivalent of the first part and the second part, both at the lab, and again, the results would be back in 1 to 2
Yeah,
weeks.
no,
But
I
you think
want
you want
to
to do it now?
know today. Yeah.
Okay, all right. So I need to ask you some questions, make sure that it's good for you and for me to be able to do that today.
Okay.
But the other thing I wanted to go back to was the timing. So you said it was about 3 weeks ago, right?
Mm-hmm.
The little test that we do here today is just, it doesn't detect the actual HIV virus in your blood. What it's looking for are the antibodies. Those are the little soldiers that everybody's body makes when they're trying to fight off the HIV infection. So those antibodies, some people grow them really quickly and some people develop them much more slowly. So some people might have enough antibodies in their body 3 to 4 weeks after an exposure to trigger this test. So this is a good time for us to do this one now. But many people will not have developed enough antibodies until just past the 4 weeks, and 5 out of 100 maybe would not develop their antibodies until even up to 3 months later. So the result that we do today is going to give us a really good idea, somewhere maybe between 90 to 95% of people in your shoes would have a result that is the final result, and that we know that they aren't going to become HIV positive. But there's that 5 out of 100 that still might take longer, and I don't know which category you're in.
So I have to have more testing?
Yes, so what I would like to suggest is that we do the test today, know that it's, that 90 to 95% chance that this is the right final answer for you. But maybe I'd have you come back in 3 months or 2 months from now, and we'll get that last test done. Okay?
I thought I'd know.
Yeah, it's a little bit frustrating, but when you think that it's 5 out of 100, that you can have pretty good confidence in this one, and at least sleep for the next few months, a couple of months until we do that last one. Okay.
Yep.
All right. So in the meantime, though, because this wouldn't be the final answer for you until that 3-month test, we need to talk about making sure that there's no chance that anyone else is accidentally exposed if it turned out that you did actually have the HIV. So, sexual contact with anybody, do you have a regular partner that you have sexual contact with?
Yeah.
Okay, so we would ask that you use a barrier method. Your partner's male, female, we talked about body parts, they're transgender people, intersex. Any of that kind of stuff needs to either use a condom or a barrier. So, are you familiar with how using those? I know you said you didn't use a condom with this guy.
But I can't use a condom with a regular partner.
Is it somebody who doesn't have a penis?
No, but then he'll know.
Oh,
right?
I see. Okay, all right.
So yeah.
Okay. Yeah, no, that's fine. That's pretty typical, right? So.
Good one.
Oh, did somebody have a suggestion or a comment there?
I just said that was a good one.
Yeah. I said, Suzanne, you're going to throw me under the bus. She promised me she wouldn't. Yeah. So
it's very common. It's very common.
It is,
right.
Absolutely.
And so, how do you give a strategy, right?
Yeah.
So
okay. So what we need to negotiate here, I guess. I mean, I can't make you do anything. I do need to explain to you that as I'm doing now, that under the law, if somebody finds out that they have that their partner had sex with them, had a reasonable chance of believing that they were HIV positive, but didn't disclose that, and that is maybe what you're telling me you might feel that you need to do. That if they found out about that, there are criminal code implications there, and I would really, I'd feel sick if I ever found out that because I didn't explain something to you or didn't help you as much as I could, that you ended up being. Is
there something you can tell me that I can tell him that maybe we can't have sex?
Well, I mean, we don't. Not for me to be suggesting that you alter the truth and all, but there are a lot of reasons that don't involve HIV, right? You can say that you're being. You're having some kind of symptoms, you have some itchiness there, you're sending some tests off, you don't know what it is. It's a better idea that we use condoms or don't have sex at all for a few more weeks, or at least even until we get these preliminary results back, right? Okay. So maybe even if we start off with that week or 2, would that be something that you could do?
Yeah, because no, we can't use. Yeah, no, I can't tell him.
Okay, and I mean, so it can be that kind of a thing. There can be other. It can. Pain, I'm being investigated for pain, and then healthcare people have suggested that I not have intercourse for a few weeks, or something like that.
Yeah, I can tell them that.
Yeah. So, but I just want to make sure that you understand that, if we think that there's a reasonable chance that you may have gotten something, that you can get in trouble with the law if you don't disclose and you do.
So you'll tell the police then?
what happens is that if the test comes back positive and it goes to public health, then we need to work with public health to make sure that everybody is safe. We don't have anything to do with the law and the criminal code stuff. We have to do with the Public Health Act, which also says you need to tell people. But it's the criminal code and those rulings that have come up with the idea about disclosing to your partner. So I want to help you with that, but I'm not a lawyer, I'm a nurse. You know, I can explain it to you the best of my ability, but you know, if you are worried about legal implications, of course you need to go to a lawyer, right? But no, the only time that anything from my office here it would be disclosed is if they had gotten a court order, and there would be nothing that I could do about that. So.
Okay, you know, I have to go, so can you just test me?
Okay, all right, let me just
I have another appointment.
Okay, fair enough. Is there any other reason that I shouldn't be testing you? I mean, I wouldn't want you to be put in a situation where you're unsafe. I want to know that you're going to be able to keep yourself reasonably okay in terms of being stressed out. I wouldn't want to realize that we shouldn't have done this test because you know, you're feeling fragile, that you might hurt yourself.
No.
Have you ever hurt yourself?
No. If I know today, it'll be good. If I know today,
okay.
yeah.
All right.
I need to know today.
Okay, good enough. Do you have people to help you if this turned out to be bad news and we had to send off the blood? And are you going to have time for me to take the blood if it's bad news?
Yeah, I
Will
can
you
stay. I can stay.
Okay, all right. So people though who will help you?
Yeah, I know a friend who's a nurse that I can talk to.
Okay, all right, good enough. And I think that probably does it then. Okay.
Okay.
Anything else that you need me to go over for you?
No.
Okay.
No.
Okay.
No. Just do it.
Okay, so I'm going to check off here then that you consent, and we're going to do one.
Yep.
Okay.
Okay.
All right. Okay, I think that's it. And then I run off and get all my equipment. Right. Yeah.
It's a good question.
Yeah. And for the routine testing, there is still some gray area, I guess. I think the understanding is that people are not going to be called routinely unless they come to a sexual health clinic where that's the standard to get their negative results, as opposed to a family practice or a GP practice where you're right, where you'll only get a call if it's bad news kind of thing. So good point. I'm sort of in sexual health clinic practice where everybody gets called with their results, but yeah, you're right. Yeah. In the in-depth counseling guide, there is actually on the second page. So depending on what Suzanne had actually said to me, I had kind of implied that she hadn't indicated to me any particular risk factors. I'm kind of in my head, I was envisioning that, you know, she's not having particularly high risk sex, but that she is sexually active and maybe has had more than one partner, I don't know. I would have put her in my own head, I was kind of assuming she was in the every 12 months one. And I had said, you know, you haven't been tested in a few years, so let's go ahead and do it. But you're absolutely right. Following those guidelines on the second page is what's encouraged. And in a practice where you don't intend to call them back to see a positive result, that would be a good point to say. That for you, I think, you know, once every 12 months is good enough. So assuming that these results are good, we'll just do it again next year. The Public Health Act, PHAC I should say, actually in their new testing guideline document does say that in circumstances it may be appropriate and necessary to give results over the phone. You know, so as long as you know it's really the person that, you know, whatever the question is that you ask them, to know it's really them, you would not be violating any inalienable code or anything like that. So yeah, you can do that for sure. I know that, I don't think Amy's on the line, but she was talking too about when you talk about public health, people oftentimes picture the nurse who's come to do their baby visit and immunized their nephew and done all of those kinds of things. And so sometimes, rather than saying public health, if you could talk about the medical health officer's office and make some kind of negotiations where it would be not the nurse who would normally be on the reserve or whatever who does the follow-up, they would know the name because they need to be aware of it. But somebody else could come, somebody else who is not known to the area could phone and make arrangements to meet in town somewhere else or whatever. So there's always ways to do that follow-up with a completely anonymous stranger staff person. So oftentimes we're able to negotiate those kinds of things too. Fair enough, and I guess I'm not accounting for, you know, if I fall ill or something like that. If I know I'm going to be away, then you're right. I do say that, you know, I'm going to be away for a few weeks, so it's just going to be one of the other nurses in my office who sees this. And we'll come looking, is that okay, or would you rather wait until I come back? And so we do, you're right, if I'm not sure that it's going to be me, then we do kind of whatever the negotiation is. Or, you know, if there's a blonde woman knocking on your door, that's my coworker Rachel, you know, so yeah, we'll do things like that, yeah. I know that those of you who have done lots of testing, you know, will have 10 different versions and scenarios and ways that you prefer, and so if you feel that you want to share that later or by email or by another discussion in another forum or whatever, absolutely.